Thank you for joining us today for cancer-associated venous thromboembolism, balancing risk and reward with modern anticoagulation. Today's presentation is brought to you by Creative Educational Concepts and is supported by an independent educational grant from the Bristol Mayo Scrib and Pfizer Alliance. My name is Marc Carrier. I'm one of the professor of medicine, hematologist at the University of Ottawa in Canada. I do venous thrombosis and cancer for a living, and it's a great pleasure to be here today and have a discussion about the new updates on cancer-associated thrombosis. And now on to the learning objective for the presentation today. Over the next 45 minutes or so, we'd like to do 4 things with you. The first one would be to identify disease, treatment, patients-related factors that will increase the underlying risk of having cancer-associated venous thromboembolism in patients with cancer, trying to assess who would be at the higher risk, and if so, how do we provide education to prevent venous thrombosis from happening? If venous thrombosis happens, what type of anticoagulation treatment strategies are available? How do we tailor anticoagulation accordingly and incorporate the different management strategies and aligning it to the most current guidelines and evidence for patients with cancer. We'll develop strategies to coordinate care amongst members of the cancer-associated venous thromboembolic team. That will obviously include yourself, but also caregivers, other healthcare providers. And we do that in order to make sure patients understand the underlying disease, the potential consequences, and achieve optimal adherence to the medication so that we have optimal outcomes for the anticoagulation management in that patient population. Now, you probably know that venous thromboembolic disease is not very common in the general population. We think about 1 or 2 per thousand, but as soon as a patient has a diagnosis of cancer, it increases the odds by about 4-fold. And if that particular patient is initiating chemotherapy, it's increasing the odds by 6.5-fold. So very common in the setting of cancer. And this was highlighted by a recent large database analysis from the Nordic countries, where they identified 500,000 patients with a first diagnosis of cancer and 1.5 million without, and compared them and followed them over 2 decades. And the first thing that they've shown is that the 6-month risk of VTE in patients with cancer is 12-fold higher compared to the general population. And if these particular patients are undergoing chemotherapy or immunotherapy, the risk is 23-fold higher. The second things they've shown is what you're seeing on this slide here, is that the 12-month cumulative risk of VTE has been increasing over time. It went from 1% to 3%, so a 3-fold increased risk over the past 2 decades, 6-fold if these patients are undergoing chemotherapy and immunotherapy. So it's something that is very common in patients with cancer. It's not something that is going away. If anything, we're seeing more and more cancer-associated venous thrombosis. Now, why is that? Well, a lot of patients will be undergoing new types of chemotherapy, and some of them may be associated with a higher risk or more thrombogenic or higher risk of having venous thrombosis. Patients with cancer are living longer, so more chance of having venous thrombosis complications. And then we're also doing more scans to follow patients over time, and we're finding incidental PEs, which have been shown to have a similar prognosis than symptomatic PEs, and therefore need treatment. So all of these things are saying that, well, patients with cancer are at higher risk, and this risk seems to be increasing. That's why you and I, when we're on service and we're seeing patients in the ambulatory care setting, we're seeing a lot of cancer-associated thrombosis. Now, this is associated with some morbidity and mortality. We know recurrent VT is associated with a higher risk of recurrence despite anticoagulation. Patients with cancer are at higher risk of having bleeding complication on anticoagulant therapy, both of which are associated with important morbidity, decreased quality of life, independent of the scale you're looking at. It's associated with increased mortality, but it's also associated with an increase in the healthcare cost and use of resources. And therefore, it may be important to identify patients that may be at higher risk of having these events and provide education so they can seek medical attention sooner, so that we can tailor anticoagulation in these patient population, avoid morbidity and mortality. So obviously, when we think about risk factors for VTE, a few things are coming to mind, some patients-related factors, cancer-related factors. We know different tumors are associated with different risk of having venous thromboembolic complication. Biomarkers and treatment-related factors are important. When we look at individual risk factors, we know that none of them on their own is good enough to predict the risk of venous thrombosis in patients with cancer. We need to have combination or risk prediction models in order to do so. And there's a risk prediction model that has been used quite a bit over the past few years. Alok Khurana and colleagues, Alok is now at the Cleveland Clinic. He derived and validated a score when he was in Rochester, New York. But it's a very simple risk factors where you look at site of primary tumors and some biomarkers. So pre-chemotherapy, white blood cell count, hemoglobin or hematocrit, and platelet count, as well as body mass index. And based on these factors, you get a certain amount of points, and you can stratify patients according to their underlying risk of having venous thromboembolic event. Low risk, so less than 1.5 over the next 6 months. Intermediate risk, up to 10%, or high risk all the way up to 20%. And based on these risk over the next 6 months, then maybe providing some education about signs and symptoms of DVTs and PEs, and in some cases, having a discussion about primary trauma prophylaxis may be desirable. So let's have a look at the prognostic significance of this. So Alok derived and validated in the setting of a neutropenia database that he had. This score has been validated in multiple different studies across a number of different populations. And a systematic review meta-analysis specifically looked at the performance of the corona risk score. And then you can see that when you look at the 3 different stratification, low, intermediate, or high risk, you have a 6-month increased risk that is increasing over time. And when you use a dichotomous type of risk factor, you still have patients that have a high risk, have a 10% risk of having VT over the next 6 months. So an overall odds ratio close to 2, which is statistically significant, so important to keep in mind. Now, there's no doubt that the corona risk factor, like anything in life, has some limitation. It was meant to be a score that is easy to use, that you can use for screening. You readily have all the information available in your clinic. But admittedly, all the different tumor types, different patients have different characteristics. So it'd be ideal to have something that is specific for tumor type, stage, and patient characteristics. So this score is meant to be generalizable and used for screening. If you look at it in certain tumor type, for example, in lung cancer patient, it may not perform as well. But overall, when you use it in a chemotherapy unit or a cancer care unit, it seems to be working well in general. So if we look specifically at a patient case, a patient that you're seeing in clinic, a 57-year-old gentleman recently diagnosed with metastatic pancreatic cancer, will be undergoing chemotherapy. You can see the laboratory findings here show that he has leukocytosis, mild anemia, and thrombocytosis. He's also known to have hypertension, which is well controlled on lisinopril. And you may ask yourself, because you've heard that pancreatic cancer has a higher risk of having thromboembolic complication, what's the underlying risk of having venous thrombosis? Well, if you apply the corona risk factor, you would know that pancreatic cancer is at high risk, so you would get 2 points for that. You would get points for is thrombocytosis as well, and therefore, based that he's at least at 3 points or more, he would be deemed to be at high risk. So his risk of having VTE complication while he's undergoing chemotherapy, so in the next 6 months or so, is probably between 10 to 15%. And therefore, patients that are deemed to be at high risk may benefit from getting some form of education, discussing signs, symptoms of DVTs and PEs, because patients don't necessarily know them. If we go to our chemotherapy unit right now and ask patients waiting for chemotherapy, do you know what febrile neutropenia is? Most of them would know that if they feel unwell, they need to take their temperature. If it's high, they need to seek medical attention, present themselves to the emergency room, or call their primary care doctor. But if you ask the same patients what the signs and symptoms of DVTs and PEs are, most of them don't know. And that's why we often see a lot of incidental findings. We see a lot of incidental PEs. So CT scan done for underlying staging, reporting PEs, and then the radiologist is calling you. Often when you talk to the patient had symptoms. They felt short of breath. They had some chest pain, but they thought it was because of the underlying disease or a side effect of chemotherapy, they did not know about the possibility of having a clot. So creating awareness is very important, and to avoid morbidity, because if these patients know that they are at a high risk of having VTE, then they'll seek medical attention, decreasing the risk of recurrence, decreasing the risk of bleeding, and hopefully decreasing the risk of mortality, because thromboembolism, so arterial and venous event, is the second leading cause of death in patients with cancer, equal with infection following the tumor, the underlying tumor per se. So it's important to keep that in mind. And then in the select patients, we'll go through clinical practice guidelines down the road, but in selected patients, providing some primary trauma prophylaxis with a prophylactic dose of a rectal anticoagulant may be desirable. 2 randomized controlled trials have shown a good risk-benefit ratio, so a relative risk reduction about 50%, but a slight increased risk of bleeding. So having a case-by-case discussion will be important. And this is referring to the guidelines that we talked about. So if you look at the American Society of Clinical Oncology in 2020, you can say that in patients that are deemed to be at high risk of having venous thrombosis, so Cron risk score of 2 or 3 or more, you may offer thromboprophylaxis with apixaban or rivaroxaban based on the studies that I was referring to, the Cassini and the AVERT trial. However, it's important to have a discussion with patients. Patients deemed to be at high risk of bleeding may not benefit. There's some costs associated with that. And these 2 trials I've looked at primary trauma prophylaxis for 6 months. So beyond 6 months, there's still a little bit of unknown. And obviously, if you're treating specifically multiple myeloma and they're receiving IMiD-related therapy, especially in combination with dexamethasone, they may be at high risk of having venous thromboembolic complication. Other scales are available to help tailor that risk, but they may require some form of trauma prophylaxis in the form of a rectal anticoagulant or low-microwave heparin. But in some cases, we won't be able to prevent clots from happening. Venous thrombosis, as I mentioned, is very common in the setting of cancer, and patients will show up with lower limb proximal deep vein thrombosis or pulmonary embolism, and will need to tailor anticoagulation accordingly. And there's been quite an evolution of anticoagulant therapy over the past few decades, and especially over the last 5 to 8 years, it's been incredible. So we can go all the way back to unfractionated heparin, vitamin K antagonist, low microwave heparin, and really the trials that have compared specifically in the setting of cancer, low microwave heparin to vitamin K antagonist or warfarin in the early 2000s, that really framed practice recommendations of using low microwave heparin as the first line. We'll come back to that, but 5 or 6 randomized controlled trials have compared different low microwave heparin and enoxaparin, dalteparin, tinzaparin to warfarin with good effect. And it's only in 2018 where we're starting to have data with the rectal anticoagulant, apixaban, rivaroxaban, edoxaban, compared to low microwave heparin for the management of cancer-associated thrombosis. So we'll look at all the data together to try to figure out if there's certain patients that would benefit from low microwave heparin or a rectal anticoagulant, and how do we tailor anticoagulation in that patient population. So, as clinicians, when we make a decision about treatment, there's different consideration on what to think about. Obviously, we want to think about efficacy, safety, and then based on that, is there a patient population that would benefit or could be harmed by a certain type of anticoagulant? So we'll look at tumor type. We'll look at intracranial disease, so primary brain tumors, but also metastatic brain lesions. We'll look at drug-to-drug interaction. Is that important or not? We look at other comorbidities. Some patients may have gut resection, so is that absorption issue? Is hepatic function an issue? And then obviously we'll look at preference, and then we'll try to come up with a summary of the recommendation based on that. So let's look at efficacy and safety first. And then I mentioned that in the early 2000s, a number of randomized controlled trials that looked at different low microwave heparin. So that would be, for example, enoxaparin, dalteparin, compared to warfarin, an INR between 2 and 3. And as you may or may not know, when we look at efficacy in VTE-related trials, we always look at recurrent venous thrombosis despite anticoagulation as being the efficacy outcome measure of choice. And that's what you're seeing on your left-hand side. So you can see from the systematic review meta-analysis that patients with cancer and venous thrombosis, when they receive low microwave heparin, they have less chance of having recurrent VTE compared to warfarin, and therefore low microwave heparin is more effective. It will decrease the risk of recurrent VTE by about 50%. And when we look at outcomes of safety, we usually look at major bleeding, which would be, for example, bleeding in a critical site, fatal event, intracranial bleeding, or a site like a joint, retroperitoneal, or a drop in the hemoglobin or hematocrit by 20, or 2 units of packed red blood cell transfusion. That would be the major bleeding definition from the ISTH, the International Society of Thrombosis Hemostasis. It has some limitations, but at least it's a standardized definition. And what you can see on your right-hand side when you look at the major bleeding based on that definition, there are no difference with low molecular heparin and vitamin K antagonists. So these early trials in the early 2000s showed that low molecular heparin was more effective as safe as vitamin K antagonists. So it was a slam dunk for clinical practice guidelines to recommend low molecular heparin as first-line therapy for these patients when it was practical to do so and cost was not an issue. Now, obviously, low molecular heparin is an injection, often once or twice a day. It's expensive. So really, there was some eager to see if a directal anticoagulant, so rivaroxaban, dabigatran, apixaban, or edoxaban, could be used in that setting. And obviously, we had a lot of data comparing the different directal anticoagulant to warfarin for DVT and PE, not specifically in the setting of cancer, but it was only in 2018 that we had to wait for until we had the first trial comparing a DOAC, edoxaban, to low molecular heparin, dalteparin in that setting. And that's the Okusai VTE trial that you're seeing on your left-hand side. So there was a large non-inferiority open-label randomized control trial comparing a DOAC to low molecular heparin and following patients for 12 months. A month after in JCO, Select D trial, much more modest sample size compared to rivaroxaban at the P and DVT dosing. So remember, this is 15 milligrams PO BID for 21 days, and 20 milligrams PO daily thereafter compared to dalteparin. Followed patients for 6 months with a primary outcome of recurrent VTE. And 2 years later, in 2021, we had Caravaggio, the largest of the randomized control trial, comparing apixaban to dalteparin or low molecular heparin. Remember, again, the apixaban is PE and DVT dosing, so that's 10 milligrams PO BID for 7 days, and 5 milligrams PO BID thereafter. And you look at recurrent VTE as the primary outcome measure. There is a smaller trial as well called IDEM VTE that was done in the Mayo Clinic system that compared apixaban to low molecular heparin. So a lot of data that was has been done over the past 4 or 5 years in order to provide more insight on the safety and efficacy of DOACs in that setting. When we combine all this data together, so when we combine, we now have 6 randomized control trials comparing different DOAC to low molecular heparin for patients with cancer-associated thrombosis. You can see on the top, when you look at efficacy, that it looks like DOACs are more effective than low molecular heparin because there's a relative risk reduction of about 30%, an absolute difference of about 3%, and people that receive a DOAC had less risk of recurrence. But when you look at the safety outcome, and you look specifically at major bleeding at the bottom, although it was not statistically significant, some of the studies have shown that some of the DOACs may be associated with a slightly higher risk of bleeding complications. So it's important to keep that in mind when we're tailoring anticoagulation. We'll come back to that. When we look at the major bleeding within the different studies, and we look, remember, we talked about the major bleeding definitions, right? So when we look at the comparisons between those receiving DOACs and those receiving low molecular heparin, and then you're trying to figure out what type of bleeding was more common in patients receiving a DOAC, there was no difference in fatal event or intracranial events. The big difference was gastrointestinal type of bleeding, specifically upper gastrointestinal type of bleeding. So from a major bleeding perspective, patients receiving a DOAC may be at slightly higher risk of upper gastrointestinal type of bleeding. And therefore, if you have concerns about that, then maybe initiation of a DOAC may not be the right thing to do, but we'll come back to that when we look at clinical practice guidelines. And then some people also like to look at clinically relevant non-major bleeding. Why is that? Well, if you have a patient that has, for example, bladder cancer, started on anticoagulation, has hematuria, needs to go to the emergency room, has a cystoscopy, needs total bladder irradiation, needs 1 unit of packed red blood cell. I think you and I both agree that this is an important bleeding event, but as you notice, it doesn't really meet the criteria for major bleeding. So clinically relevant non-major bleeding is also important to assess because these are important to clinicians and patients requiring unscheduled appointment, using resources. And when you specifically look at clinically relevant non-major bleeding, patients receiving DOAC had a higher risk of bleeding, so an absolute difference of about 4%, relative difference of about 65%. And when you really look down, you do a deep dive in clinically relevant non-major bleeding, a lot of these bleeding events are gastrointestinal type of bleeding and genitourinary type of bleeding. And that's maybe why when you look at clinical practice guidelines using the American Society of Hematology or the American Society of Clinical Oncology or the NCCN, they're probably saying, well, you need to be mindful of using a DOAC if you have an unresected GI or GU type of lesion, because you may increase the underlying risk of clinically relevant non-major bleeding and maybe increasing the risk of major bleeding in certain situations. Now, is there a type of tumor that you need to be mindful of? Well, this is a post-hoc analysis of the Okusai VTE cancer. So remember, this is the New England Journal paper in 2018 that compared edoxaban to low microwave heparin. And they showed an increased risk of major bleeding in that particular trial. So the investigators said, well, can we try to identify who was at higher risk? Remember, it's still a small number of events, but when they stratified patients according if they had a gastrointestinal type of tumor or not, you can see on your left-hand side that patient that had a gastrointestinal type of tumor and received edoxaban, they had a fourfold higher risk of having bleeding complication, most of which were gastrointestinal type of bleeding compared to those receiving dalteparin, and certainly no difference in the non-GI cancer. And that's part of the rationale, while some of the clinical practice guidelines said, well, you need to be mindful of initiation of a direct anticoagulant in patients that have a gastrointestinal type of tumor. Now, are there other patient characteristics that may increase your likelihood of picking one agent to the other, like using low microwave heparin versus a direct anticoagulant, for example? What are the other types of features? Is intracranial disease one of them? This is something we see all the time as clinicians and present an important challenge of anticoagulation. So the first question is, if you have intracranial disease, if you have brain mets, so if you have primary brain tumor, can you initiate anticoagulation? This is a relatively recent systematic review and meta-analysis that was published in Blood Advances on one of the Journal of the American Society of Hematology. As you can see on the top, they tried to stratify based if it was metastatic disease or primary brain tumor, and then they tried to look at or do comparisons between patients that receive anticoagulation or not. Now, admittedly, this is low quality data, mostly observational, not randomized, different indication, often warfarin and low microwave heparin, some DOAC. But you can see that when sometimes this is all we have to make clinical decision, we look at on the top of metastatic disease, there's no increase in the risk of intracranial bleeding for patients with metastatic disease receiving anticoagulation. So generally, if you have a patient with METs, new indication for anticoagulation, I don't lose sleep about initiative anticoagulation. Now, admittedly, some patients may have highly vascular tumors, renal cell carcinoma, melanoma, for example. They may still have a slightly higher risk, but if there's no signs of bleeding on the most recent CT, if there's concern, you can always repeat a CTN, but usually there's no concerns of increasing the risk of intracranial hemorrhage with anticoagulation. But if your patient has a primary brain tumor, now these gliomas, for example, are quite heterogeneous in nature. Some people will need surgery or radiation, or may require chemotherapy. So or CyberKnife. So in this setting, when you look at the risk ratio, you can see there's an increased risk, about fourfold increased risk of intracranial hemorrhage for those receiving anticoagulation. But if you have a new indication, you probably have to have a case-by-case discussion assessing what the risk-benefit ratio. Now, is the presence of metastatic disease or primary brain tumor making you pick a DOAC versus a low microwave heparin or vice versa? Well, it doesn't look like there's much difference. And this is a nice little observational study published in the Journal of Thrombosis and Hemostasis, the Journal of the International Society of Thrombosis and Hemostasis, It's the group by Jeff Zwicker when he was in Boston. He's now at MSK. But you can see that they looked at their own data in Boston, stratified them if their patient had primary brain tumor on your left-hand side, brain mets on the right, and then looked if they received a DOAC, which was mostly rivaroxaban, or low molecular weight heparin, mostly enoxaparin, followed them over time. Now, admittedly, this is observational study. There's a lot of limitation. It's hypothesis generating only, but provides some reassurance because when you look at the two curves, there's certainly no increase in the risk of bleeding for patients that have received a DOAC compared to a low molecular weight heparin, independent on the type of patient population. And that was shown again in this study that was a collaboration between folks in Israel and the Netherlands. And they followed patients. This is only brain mets, though, but followed patients over time. And you can see that there is no increased risk of intracranial hemorrhage in patients receiving a DOAC compared to a low molecular weight heparin. In fact, it seemed to be the opposite. Now, again, observational studies, lots of reasons why clinicians may have picked the low molecular weight heparin or DOAC. It's not randomized hypothesis generating, but still reassuring. And there's a more recent analysis that showed similar things. So it's not, I don't use the presence of metastatic disease or primary brain tumor as one of the characteristics that will make me pick an agent over the other. However, keep in mind that low molecular weight heparin has a much smaller half-life or shorter half-life compared to a direct anticoagulant. So some people feel more comfortable using it. If there's intracranial hemorrhage complications, some people may feel more comfortable managing a bleed with an enoxaparin or vice versa with a DOAC. So it really depends on the case by case and the resource available within your center. Now, is our drug-to-drug interaction something that you should also consider? And that's important because when we use enoxaparin or low molecular weight heparin mostly, there are no real drug-to-drug interaction. Sure, there's some interaction with anti-inflammatory medication, antiplatelet, but not really a drug-to-drug interaction and pharmacokinetic perspective too much. There's no doubt that the direct anticoagulants have less drug-to-drug interaction compared to warfarin, but they still have important drug-to-drug interaction that are important to consider. They're dependent on the CYP3A4 metabolism and on the glycoprotein P for absorption. So if you have strong inhibitors of the CYP3A4 or the glycoprotein P, it may lead to a higher level of your DOACs, and that may increase the risk of bleeding. And if you have strong inducers, both pathways, then that may lead to lower levels and therefore higher risk of having recurrence. And then the drug-to-drug interactions are slightly different between the different DOACs. So apixaban and rivaroxaban have a very similar type of drug-to-drug interaction class. And then edoxaban and dabigatran have similar interactions because they're more dependent on the glycoprotein P compared to apixaban and rivaroxaban. Now, this is all theoretical in nature, and you may be wondering, well, Mark, is there any formal, clinical, important interaction that we should be aware of? And we're not actually too sure, and the data is a little bit on both sides. So I'm providing you with examples that shows that maybe we should be mindful with a certain type of medication and some reassuring data as well. So the TAC-DOAC was a prospective cohort study from the International Society of Thrombosis Hemostasis, looking at patients on a DOAC and targeted anti-cancer therapy. They showed high bleeding risk complication, especially in patients receiving BTK inhibitors, so the CLL type of medication. Another cohort of smaller group showed both increased risk with enoxaparin and a direct anticoagulant when VEGF TKI were used. And then other post-hoc analysis, for example, the Caravaggio trial, remember, comparing apixaban to low molecular weight heparin, did not show any difference for patients in the risk of recurrence or bleeding for patients receiving anti-cancer treatment, specifically chemotherapy, compared to those that were not. Now, having said that, drug-to-drug interactions are very specific, so you're a pharmacist, you know that you need to look at a certain indication per se. And if you look outside of the cancer-associated thrombosis arena, this is an example showing that may have a clinically important difference. So this is a large database looking at patients that are on the DOAC for various indication, mostly atrial fibrillation, but they looked at patients that receive a prescription for clarithromycin, for which is an important drug-to-drug interaction, should not be used concurrently, and those that receive a prescription for azithromycin, for which there are no drug-to-drug interaction with the different DOACs. And you can see here in the table, and as a conclusion, that patients that had a drug-to-drug interaction had a higher risk of having a hospital admission for a bleeding complication within 30 days of the interaction. So it was small, but still present. So if you have a drug-to-drug interaction, then maybe use an alternative agents. We have different DOACs are available. We have parenteral anticoagulation is also available. So while you have a certain drug-to-drug interaction and maybe for a short and medium-term interaction, maybe changing agent may be desirable at that particular time. And then there's other things where it was shown not to be important. So for example, if you've been treating cancer associated for thrombosis for a while, and you look at narrative reviews in 2018, and tamoxifen was one of the things that was listed to avoid DOACs with, because it has a potential drug-to-drug interaction through the metabolism pathway we just talked about. And then when we specifically looked at large databases again, Sufei Wang and colleagues have shown that there really is no difference between patients taking tamoxifen and the DOAC compared to those without any drug-to-drug interaction, like an aromatase inhibitor, for example. Again, showing that we really need to look at all the different combinations until we've proven that there's no concern. Then maybe using an alternative is the right thing to do. Now, patients with cancer will also have all sorts of other comorbidities, right? They may have resection, they may have inflammation in their gastrointestinal tract, and that may lead to decreased absorption. So it's important to remember that the different DOACs are absorbed throughout the gastrointestinal tract, that they're absorbed through different places, and that may lead to lower level. If there's absorption concern, then maybe you should use an alternative. So edoxaban is mostly absorbed in the proximal small intestine, rivaroxaban in the stomach, and apixaban is absorbed throughout the GI tract, and then particularly at the distal small bowel and the ascending colon. So if you have a patient that has a certain resection, and then you're concerned about absorption, so Roux-en-Y, for example, then maybe using edoxaban, rivaroxaban is not the best. Then you should be using apixaban in that particular setting, and vice versa. So it's important to be mindful. Now, are these related to clinically important difference in the levels that would lead to clinical outcomes? We don't know, but we have alternative, and therefore why not use an alternative if there's a concern? And similarly for liver disease, we mentioned that the DOACs are dependent on metabolism through the CYP3A4, and therefore if there's liver dysfunction, you may affect clearance. And you can see that edoxaban is less dependent on hepatic clearance compared to rivaroxaban and apixaban, and therefore you need to be mindful of using these agents if there's severe renal dysfunction. In the clinical trials, patients were excluded if they had a child Pew C, for example. Child's Pew B was okay with edoxaban and apixaban, and child Pew A, then all the different DOACs were used in that setting. So having a look at functional liver dysfunction may be also important, because we have different options. Then using an alternative agent, if there's concern, may be desirable. And obviously, patient's perspective is important. And when patients are seeing you or I with their clots, the first thing that they have on their mind is, Mark, do whatever, but don't interfere with my anti-cancer treatment. Don't postpone my surgery if you can. Don't change my chemotherapy. So that's the first thing that we need to account for. After that, attributes from patients, sure, we want something that is effective and safe. And then third is the route of administration. And the reason why I'm putting these in that particular order is because patients selected that particular order, so that you can sometimes go from an oral agent to parenteral agent and vice versa, depending on what's ongoing in the underlying patient's journey of cancer. If they are going for surgery, then maybe you need to switch them to parenteral agent for a while, or if there's a drug interactions before we challenge them to an oral agent and vice versa. And the patients will accept that. They'll accept that you tailor anticoagulation. You just need to they need to understand why. So if you sit down with them and explain why you're doing this to make sure that there's no interference with the cancer treatment, safe and effective, and then we may use oral versus parenteral for a while before re-challenging, they'll be very willing to do so. Now, this work was done by Simon Noble and colleagues from the United Kingdom. Professor Noble is based in Cardiff. He's a palliative care doctor. And if you look at the reference, you look at it's 2015. So this was when we would use low microwave heparin anyway. The alternative was warfarin. And it was before we had data on the DOAC. So maybe this patient perspective is outdated a little bit. But Professor Noble and colleagues repeated this mixed study doing interviews of patients more recently alongside of the SELECT-D that compared rivaroxaban to low microwave heparin and found the exact same results and same conclusion. So independent if we have DOAC, warfarin, or low microwave heparin, first thing on patient's mind is no interference with cancer patients, then it's efficacy and safety, and route administration comes last. So if we put all that together, if you look at the American Society of Hematology, the 2021 guidelines, what they're recommending is in the setting of an acute clot, then the ASH guidelines suggest a directal anticoagulant, apixaban and rivaroxaban, or low microwave heparin for the initial treatment, so the first few days. Why is edoxaban not there? Well, remember, if you want to use edoxaban, there's a 5-day leading of low microwave heparin in all the clinical trials. So that's why apixaban, rivaroxaban specifically listed for the acute phase, as well as low microwave heparin. And for the short term, the initial 3 to 6 months, then they would suggest a DOAC, apixaban, edoxaban, rivaroxaban over low microwave heparin based on the data we said. But if you looked at the fine prints, they say if your patient's high risk of bleeding, then be mindful that maybe using a low microwave heparin like enoxaparin, for example, may be desirable in that patient situation. So what the NCCN guidelines is saying, more or less the same thing. Apixaban, edoxaban, rivaroxaban are preferred for patients without gastric and gastrointestinal type of lesions, because remember, DOAC seems to increase the risk of bleeding complication, certainly clinically relevant non-major bleeding, possibly major bleeding, at least some of the agents. And it seems to be these bleeding complications seems to be gastrointestinal, mostly upper GI type of bleeding. So that's why the NCCN is quite specific. So low microwave heparin is preferred for these patients. And treatment to prevent blood clots, so primary prevention is not recommended in low-risk patients, but they suggest to consider primary prophylaxis for patients that are deemed to be at high risk based on their current risk score, as we saw. And if you want to have a bit more information, then you can use the QI code. Now, what do I usually do in my clinic? So I have a patient with proximal lower limb DVT or PE or proximal upper extremity DVT. The first thing I think about is this patient's high risk of bleeding? They had prior history of bleeding. Is there unresected high risk GI lesions? Are they thrombocytopenic? And I looked at renal and liver impairment. And if they're unindicated, I ask myself why they're on it. And if there's no indication to be on top of anticoagulation, I usually discontinue it. But if these patients are high risk of bleeding, maybe challenging to a low microwave heparin may be desirable, at least early on before transitioning to a direct anticoagulant. Type of tumor is important. We mentioned unresected intraluminal GI and GU cancers. So if these patients have these types of tumors, then maybe I would re-challenge, or I would challenge them to anticoagulation with a parenteral agent first, make sure they're not bleeding, and then transition them to a direct anticoagulant. Same thing with drug-to-drug interaction. But for a large majority of patients that are not filling these different criteria, a direct anticoagulant is preferred. And obviously, there's going to be some practice variation based on your setting, where you practice. Preference will be important, once a day, twice a day, drug cost, body mass index, absorption, these types of things also need to be included in consideration. for the right agent for a particular patient. So in order to get the patient engaged, first understand, and then get engaged and understand why blood thinners are important and to prevent morbidity, mortality associated with it, I think it's important to have the patient really centered into the discussion. So how the patient is receiving education, do they feel like they have control? Do they understand the underlying disease, the risk factors, the importance of taking the medication or not, and the review of patient and providing patient-related information material may be important so that they feel that they can own the disease and be engaged in the underlying treatment, be compliant overall. Because when you look at patients and you look at blood clots education in the setting of oncology clinics, we're not doing very, very well. So this is a 1,000 patient survey. 50% of patients had more than 3 healthcare visits before being correctly diagnosed with a blood clot. 55% felt their diagnosis was explained to their satisfaction, so there's lots of room for improvement. And 60% responded receiving print or electronic information on blood clots. So again, certainly lots of room for improvement, and we'll show you some patient information material that you may want to use. 97% remembered being treated with anticoagulation, but only 48% recall being told any specific information, including the risks and benefits, what to watch for example, bleeding signs, symptoms, when to seek medical attention. So I think patients' resources are really important. You can have a look here to the educational material you've received, but there's different national organizations, the National Blood Clot Alliance, for example, the North American Thrombosis Forum also. So SMART goals following this presentation. So SMART goals need to be specific, measurable, attainable, relevant, timely. So put information into action, consider the following goals, then set a time frame that fits with your own work environment at a reasonable improvement target that aligns with the patient population. So one of the things to consider might be increasing the percent of patients with cancer who are assessed for VTE using a VTE-related risk score or a bleeding-related risk score, and providing them with risk-benefit ratio. Ensure that each patients are compliant with prescribed VTE prophylaxis or treatment as documented by patient-reported behaviors and medication that you can have in your electronic medical record, and increasing the percent of patients who participate in therapy decision using shared decision-making as documented by increased delivery of patient education to their health care. Okay, so the first question in the Q&A is, how long should patients receive DOAC after VTE? So assuming the question is related to proximal lower limb DVT or pulmonary embolism, usually we do a 6-month course of anticoagulation. After 6 months, then if the patient is in remission, then you can safely discontinue anticoagulation, because after the initial 6 months, the clot is cured. The rationale to pursue beyond 6 months is for secondary prevention. So if the clot is gone and the risk factor is no longer present, we usually can stop anticoagulation. If they're still undergoing treatment or there's underlying cancer, like patients with metastatic disease, then we tend to continue anticoagulation beyond 6 months for secondary prevention. Now, can you reduce the dose of DOAC? Let's say you're using apixaban, the patient's been on apixaban 5 milligrams PO/BID. Can you reduce it to 2.5 BID? We don't know just yet. There's a trial called APICAT that will be done in September 2024 that has compared over 1,500 patients with cancer-associated thrombosis and compared 5 to 2.5 BID for secondary prevention. So that will provide data to support dose reduction after 6 months. There's a small trial that was presented but not yet published last summer in 2023 called the EVE trial, comparing 2.5 to 5. And the trial was small, so maybe not powered to detect any difference. But when you look at the point estimate, they were very similar. And therefore, one could say that maybe there's no difference. So I guess I would do a case-by-case basis. If your patients have really high risk of recurrence, low risk of bleeding, I would probably continue on with the 5 BID. If on the opposite, patient may be at high risk of bleeding, lowish risk of recurrence, and decreasing the dose may be desirable. Hopefully that is helpful. The second question is, how would you switch a patient between low microwave heparin and low microwave heparin to DOAC? What are the safety issues? So assuming that the patients have creatinine clearance that are above what is recommended, let's say that we use over 30, so we can use low microwave heparin and direct oral anticoagulant, then I would just switch a tablet for the needle or vice versa at the time that is next scheduled. So for example, if your patient is on apixaban 5 milligrams POBID and needs to go on low microwave heparin, I would say, well, tomorrow morning, instead of taking your apixaban dose, then take your low microwave heparin instead of the needle. If it's dosing that is once a day of low microwave heparin or twice a day, then I would continue that. Although there's differences in the half-life between the product. We mentioned enoxaparin 6 hours, DOAC is between 10 to 14, depending on the agent. There's no concerns about replacing one by the other, assuming good renal function. So there's no safety issues related to that. Are there clinical scenarios in which you may consider low microwave heparin over a DOAC or vice versa? It's another important question. So I think, as I mentioned, I would tend to consider low microwave heparin first line for patients with gastrointestinal or genitourinary unresected tumors. DOACs makes your mucous membrane very prone to bleed. So I tend to challenge them to a low microwave heparin instead of a DOAC. If a patient is thrombocytopenic, I feel like low microwave heparin, we can use intermediate dosing. We can tailor dosing a little bit more compared to DOAC. Not that we can't do it with DOAC, but we have a bit more clinical experience. So in patients with renal dysfunction, I tend to, with thrombocytopenia, I tend to use low microwave heparin. And in the perioperative setting, I tend to use low microwave heparin. Otherwise, I'm use DOAC quite a bit, unless there's a particular concern, as we previously highlighted. What are the cancer therapy classes that have been at increased risk of VTE? So, the platinums type of chemotherapies have been shown to be at higher risk. It's included, and we didn't look at all the different risk predicting models, but it's included in some of the models. So platinum-based chemotherapy. I was thinking about multiple myeloma, so the IMiDs would be another type of immunomodulatory type of chemotherapy. Checkpoint inhibitors may be associated too. Remember that some of these treatments are relatively recent, so we're still learning what's the underlying risk of VTE, and sometimes we use them more for second or third line. So is it really a treatment effect, or is it like a staging type of effect? What is known, though, is that the current risk score seems to be good at stratifying patients independent of the type of chemotherapy they're getting. So maybe include the type of therapy has a higher risk of having VTE, but really risk stratification to begin with are patient-related factors, including biomarkers like the CBC parameters we talked about, maybe a bit more important in that setting. But an excellent question again. And then, how do you manage a patient who experiences VTE if they have cardiomyopathy like hypertension, CHF, or COPD? So I tend to, I would say that the first thing is obviously wondering if the patient requires hospitalization for observation. If the patient requires hospitalization, I tend to use a parenteral agent, and then I would switch them to a direct anticoagulant upon discharge. If from a cardiopulmonary perspective, unless they have submassive or massive PE for which they may require additional intervention, I don't tend to look at other comorbidities too much. So cardiopulmonary like hypertension, CHF, and COPD. I tend to make sure that if they are on other agents, for example, antiplatelet, which may increase the underlying risk of bleeding, I tend to make sure that if they don't have a firm indication for it, or if anticoagulation could be used for primary or secondary prevention of arterial event in that setting, then I tend to discontinue antiplatelet to mitigate the higher risk of bleeding. But other than that, I don't have any special uh, uh, things that I look for specifically to make a decision about which anticoagulant to use. Hopefully that's answering your question. So I thank you very, very much for attending the presentation. Hopefully it was helpful, and I wish you a very nice day. Thank you.